Welcome to the deep dive. You know, if you've ever wondered why psychiatric diagnosis can be so tricky, well, the core issue is this. These symptoms aren't totally foreign things. They're often really complex, pathological twists on normal human function.
Exactly. And figuring out that line between, normal variation and actual illness, that's the constant puzzle for clinicians.
So today, we're diving straight into the essentials for understanding this.
We are. We're drawing from a really foundational source, the chapter on clinical manifestations of psychiatric disorders in Kaplan and Sadock's 11th edition. Think of it as a map for how illnesses actually present themselves.
And our mission.
It's to give you a clear, structured grasp of the modern diagnostic approach, the key symptom areas, and the underlying factors that shape how a patient shows their distress, all designed for quick, thorough knowledge.
Okay, let's start with the framework.
Yeah.
The DSM-5, that's the big diagnostic manual, right?
Mm.
It moved away from just rigid boxes.
Right, it shifted towards a more dimensional or multidimensional model. The idea was to better capture the spectrum of how patients actually present, improve validity.
But you mentioned diagnosis still often comes down to the clinician's judgment, not just scales.
Yeah.
If the framework's better, why is that?
Yeah, that's a critical point from the source. Even with this dimensional shift, we're still kind of lacking in really solid, validated screening and assessment scales.
Ah.
So this gap means clinicians have to rely a lot on something called concept-driven perception.
Concept-driven perception.
Yeah.
Like what you expect to see changes what you actually see.
Precisely. The clinician's own theoretical background, their bias, it limits what they notice. The text gives a great example.
Okay.
Imagine a patient moving very slowly. A psychodynamically trained psychiatrist might see that and think psychomotor retardation, an emotional functional issue.
Right.
But a neuropsychiatrist looking at the exact same slow movement might label it bradykinesia, thinking more about a structural cause, maybe a mood disorder.
Wow. Same behavior. Totally different interpretation. That must seriously impact reliability, getting different clinicians to agree.
It does. And there are other reasons clinicians reach different conclusions. One is just information variance. You simply can't ask every possible question in an assessment.
Sure, time is limited.
And the other big factor is patient reluctance. People don't always share everything. There's this striking study mentioned, if you just wait for patients to spontaneously report medication side effects, the rate for sexual side effects was about 14%.
Okay, seems low.
But if the interviewer directly asked about them, it shot up to 58%. Huge difference.
That reluctance really brings that case example to life, the 52-year-old school teacher with depression.
Yeah, she was deeply embarrassed, didn't want to bring up the sexual side effects from her medication, even with her psychiatrist.
So getting the full picture is a real challenge.
It is, and it underlines that you have to see symptoms in context. It's not just a checklist. It's how that individual is trying to cope with this mix of biological, psychological, and environmental pressures.
And speaking of environment, the source mentions newer stressors too.
Right. Things like COVID-related issues, the neurosensory symptoms, the long-term physical stuff, plus the social isolation that followed. These are now seen as important factors contributing to depression and anxiety.
Okay, so context is key. Let's shift to the roots then. Where does this vulnerability start? Genetics obviously play a role in big things like schizophrenia, dementia, mood disorders.
Definitely. But the biological story starts even earlier, in the womb. Intrauterine factors matter.
Like what?
Well, the text points to things like severe maternal starvation or maybe influenza during pregnancy, possibly playing a role in schizophrenia later on, and of course fetal alcohol syndrome from maternal alcoholism.
And what about temperament? Those early personality styles we see in babies.
Yeah, those persistent variations right after birth activity level, how intensely they react, attention span, these things can shape later vulnerability, like being highly introverted or having high neuroticism could predispose someone when stress hits later.
It's not just psychological vulnerability, though. Physical illness is a big factor too, right?
Absolutely. Metabolic problems, toxins, infections, they can all increase psychiatric vulnerability or sometimes mimic psychiatric disorders outright.
Mimic them.
Yeah. Think about PANDAS, that's pediatric autoimmune neuropsychiatric disorders associated with strep infections. It can trigger OCD or tics, often with mood swings and anxiety mixed in.
Which is why ruling out physical causes is so important, like that case of the 31-year-old accountant.
Exactly. He came in with classic panic symptoms, heart palpitations, dizziness, thought it was severe anxiety.
But it wasn't.
Nope. It turned out he had a pheochromocytoma, a type of tumor causing those physical symptoms, a purely medical issue presenting psychiatrically.
Wow. So it all comes together then, genes and environment interacting.
That's the core idea. Your genetic makeup influences how you respond to stressful life events. The chapter mentions research on a specific serotonin receptor gene, the 5-HT-TLPR polymorphism.
Great.
It found that people with a particular version, the short allele, had significantly higher rates of depression and suicidality if they experienced stressful events, losing a job, housing problems, that kind of thing, compared to people with the long allele.
So the gene created the vulnerability and the stress triggered it.
Precisely. The vulnerability is often waiting for the stressor.
Okay, so we have vulnerability. How does it actually manifest? Let's talk about thinking. The source distinguishes normal, maybe illogical thinking from pathological disturbances.
It does, using the concepts of primary and secondary process thinking.
Explain those.
Okay, so primary process thinking is sort of primitive. It's driven by fantasy, ignores logic and time like in dreams or in psychosis. Secondary process thinking is your logical, reality-based, goal-directed thought, planning, abstraction, linear time.
And pathology is when the primary process kind of leaks into the secondary.
Basically, yes. And you can see this first in the flow of thought. If it's really slowed down, that's called retardation, common in depression.
And if it's too fast?
If it's rapid, excessive, hard to interrupt, that's pressure of speech. You see that a lot in mania. And even faster is flight of ideas, where thoughts jump rapidly from one topic to another, but you can usually still follow the links, the associations.
What about when the connections break down, the continuity?
Right, that's where diagnostic distinctions get really crucial. There's circumstantiality, the person goes off on tangents with lots of detail, but they do eventually get back to the original point.
Okay, bit long-winded, but they get there.
Exactly. Contrast that with tangentiality, they wander off and never return to the point.
Oh.
And then the most severe breakdown is loose associations. The thoughts just don't connect logically at all. That's a real hallmark of schizophrenia.
And it can get worse?
It can degrade into word salad, just an incomprehensible jumble of words and phrases.
And then there are disturbances in the control of thought. These sound particularly severe.
They often are. These are the delusional passivity experiences. Things like thought insertion, thought withdrawal, and thought broadcasting.
Meaning?
The person feels like external forces are putting thoughts into their head, pulling thoughts out, or that their private thoughts are being broadcast to others.
Like that case example, the young man with the hat.
Yeah, the 20-year-old wearing an orange hat lined with wires because he genuinely believed unnamed people were extracting thoughts directly from his mind. That's thought withdrawal.
Okay, shifting from the form and flow to the content of thought beliefs.
Right. Here we distinguish different types of abnormal beliefs. First, overvalued ideas. These are unreasonable, strongly held beliefs, but maybe not completely bizarre or impossible. Like the intense, distorted belief about one's appearance in body dysmorphic disorder. It's extreme, but not technically delusional.
Then ideas of reference?
That's when someone falsely believes that ordinary events or remarks are specifically directed at them, like thinking random cell phone rings or signals about you.
And finally, delusions.
Yep. Fixed, false beliefs. Strongly held, resistant to evidence, and not something shared by the person's culture or background. Importantly, they aren't specific to just one diagnosis.
The source mentions primary delusions.
Yes, a key distinction. A primary delusion, like an autochthonous delusion, seems to arise out of nowhere, a sudden, powerful conviction without any preceding thought process leading up to it. Just bam, the belief is there.
Okay, now let's switch from thinking to perception. Illusions versus hallucinations.
Crucial difference. An illusion is a misinterpretation of a real external stimulus. Seeing shadows move and thinking it's a monster. There's actually something there to misinterpret.
And hallucinations.
Those are perceptions experienced when there is no external stimulus at all. The person hears voices, sees things, feels things that aren't there, but subjectively they feel completely real.
Like hearing voices.
Exactly. Auditory hallucinations are the most common type in schizophrenia. The text says 60 to 90% of patients experience them.
And there are specific types associated with schizophrenia.
Yes, the chapter highlights 3 classic types. Hearing your own thoughts spoken aloud, hearing a running commentary describing your actions, or hearing 2 or more voices arguing with each other, often about the patient.
What about command hallucinations? Voices telling the person to do something.
Those require immediate assessment.
Mm.
The clinician must figure out if the patient feels compelled to obey and what the command actually is. They can range from harmless, like say thank you, to extremely dangerous, like kill your mother. Assessing the risk is vital.
Absolutely critical. Okay, let's move to the emotional landscape disturbances of mood, anxiety, and volition. First, just basics. Mood versus affect.
Right. Mood is the sustained, underlying feeling tone, like the climate. Affect is the moment-to-moment observable expression of that emotion, like the weather.
Got it. So in depression, what's key?
The cognitive triad is central. Pervasive feelings of worthlessness, helplessness, and hopelessness. And it's really important to distinguish clinical depression from normal bereavement or grief.
How so?
Normal grief involves intense sadness, sure, but it usually doesn't have the profound pathological guilt and self-blame that often comes with a major depressive episode.
Like in the case of the woman who lost her baby.
Exactly. The 33-year-old woman described her low energy and overwhelming guilt wanting to join her baby that crossed the line from grief into a potential depressive disorder needing urgent attention.
Which leads directly to assessing suicide risk. What are the main predictors?
The single biggest predictor, according to the text, is a history of past suicide attempts. Others include intense hopelessness, anhedonia, the inability to feel pleasure, and there's even a biological marker mentioned, low levels of CSF5-HIAA, which is linked to impulsivity.
Okay. On the flip side, elated moods.
We distinguish hypomania from mania. Hypomania involves increased energy, confidence, maybe some poor judgment, but the person is still somewhat functional. Mania is the extreme state, severe disruption in functioning, often intense irritability, and frequently psychotic symptoms like delusions.
Now, anxiety. The core difference between anxiety and fear.
Anxiety is typically a response to a vague, undefined, or internal threat. Fear is a response to a known, specific, external threat.
And state versus trait anxiety.
State anxiety is temporary, situational, like feeling anxious before a test. Trait anxiety is more of a long-term personality pattern, being generally hyperreactive and anxious across many situations.
What about phobias?
Those are specific, irrational fears that lead to active avoidance of the feared object or situation. And the source notes how these evolve, mentioning coronaphobia as a contemporary example.
Fear of the virus leading to specific behaviors.
Yeah, like excessive cleaning rituals, avoiding mail, refusing social contact, way beyond typical precautions.
Lastly, in this section, disturbances of will or volition.
Right. Will being that bridge between wanting to do something and actually doing it. A key disturbance here is abulia, a loss or significant impairment in the ability to initiate and sustain purposeful action. You see it in severe depression and also in the negative symptoms of schizophrenia.
And OCD fits in here too.
Yes, because both the obsessions, those intrusive thoughts, and the compulsions, the rituals performed to neutralize them, are experienced as ego-dystonic. Meaning they feel alien, unwanted, contrary to the person's conscious will. It's a real struggle against one's own thoughts and urges, highlighting a pathology of volition itself.
Okay, final domains.
Yeah.
Motor activity, the self, and relationships. Let's start with motor activity. Increased activity.
We need to differentiate here. There's restlessness or agitation, which usually comes with inner tension, pacing, fidgeting, tapping. Then there's generalized overactivity, which is more about increased physical energy without that inner tension. You see this in mania or sometimes anorexia.
And decreased activity.
That can range from motor retardation, just slow movement, often seen in depression, to hypokinesia, a real poverty of movement. And then there's catatonia.
That's a whole category, isn't it?
Yeah, it's a broad group of movement abnormalities like stereotypies, which are repetitive, purposeless movements, waxy flexibility, where the person holds postures they're placed in, negativism, mutism, a whole cluster.
And critically drug-induced movement disorders.
Essential knowledge for anyone prescribing or managing psychiatric medications. Akathisia is a big one, that awful inner restlessness, inability to sit still, rocking, fidgeting. It's often a side effect of antipsychotics and can be incredibly hard to tell apart from primary anxiety or agitation.
What about longer-term ones?
Tardive dyskinesia. This usually starts late, months or years into treatment. Common signs are involuntary movements of the face and mouth, lip smacking, tongue thrusting.
And the dangerous one?
Neuroleptic malignant syndrome, NMS. It's rare but potentially fatal, characterized by severe muscle rigidity, high fever, confusion, autonomic instability, a medical emergency.
Okay, moving inward now to disturbances of the self.
This involves the breakdown of our core sense of identity feeling like one integrated person, reality integrity, feeling continuous over time, having boundaries between self and others, and feeling like the agent of our own actions.
And when this breaks down,
You can see dissociative phenomena. This is when normally integrative functions like identity, memory, consciousness get split off.
like depersonalization and derealization.
Exactly. Depersonalization is feeling detached from yourself, like you're unreal, or observing yourself from the outside. Derealization is feeling the external world is unreal or strange.
But these can happen to anyone.
Yes, that's key. Transient episodes of both are actually quite common in normal people, especially when tired or stressed. So for diagnosis, the persistence and severity are what matter.
In the most extreme form.
Dissociative identity disorder, formerly multiple personality disorder, a chronic state involving two or more distinct identities or personality states recurrently taking control, often linked to severe childhood trauma as a kind of primitive defense.
Finally, interpersonal systems. Personality traits versus disorders.
Traits are just prominent, stable features of personality. They become disorders when those patterns are inflexible, maladaptive, and cause significant distress or impairment across many areas of life. The source mentions the old DSM-IV-TR clusters, audicentric, dramatic erratic, and anxious fearful as ways to group them.
And the family environment matters too. High expressed emotion.
Yes, EE is a really important concept. It describes a family atmosphere, particularly for patients with schizophrenia or bipolar disorder, that's high in criticism, hostility, and emotional over-involvement. It's a strong predictor of relapse.
So wrapping this all up, what's the big picture from this chapter?
I think the main takeaway is this. Even with all the advances in neuroscience, genetics, and our classification systems like DSM-5, the foundation of good psychiatric practice is still clinical acumen. It's the clinician's ability to observe carefully, integrate all these signs and symptoms, and interpret them within the unique context of the patient's life. That remains absolutely central.
So knowing what these symptoms look like, how they manifest from biology right through to behavior and relationships, that's the essential first step. It helps you understand both the person and the illness better.
Exactly. That clinical integration, understanding vulnerability, context. Those are the critical pieces this chapter emphasizes.
We really hope this deep dive into the clinical manifestations of psychiatric disorders, drawing from Kaplan and Sadock, has provided that clear structure and the key takeaways you were looking for. Thank you for diving deep with us today. And with that, a warm thank you from the Last Minute Lecture team.